To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's virtual journal club. We are looking for an athletic trainer to join our team. This is a combined position working in a sports medicine clinic and at an NAIA university. Please feel free to pass our information along if you know a qualified candidate. More information regarding applying can be found on our website. For additional webinar educational opportunities, you can visit our website as well and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you are accessing the webinar on your mobile phone, please swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker this evening is Dr. Kana Takiguchi. She is originally from Japan, and she graduated from the University of Alabama with a bachelor's degree in athletic training and a master's degree in health sciences. While Kana was in Tuscaloosa, Alabama, she worked with various collegiate sports as a student athletic trainer and a graduate assistant athletic trainer. Kana completed a summer strengthening and conditioning internship at Mike Boyle Strength and Conditioning in Boston, Massachusetts. She moved to South Florida and worked at a high school as a certified athletic trainer for several years. She attended the University of St. Augustine and obtained a doctoral degree in physical therapy and manual therapy certification. Kana is a senior physical therapist at the Gloria Drummond Physical Rehabilitation Institute at Boca Raton Regional Hospital in Baptist Health. And I will transition the slides to her and we will have her take it away at that point.
Show my screen.
Perfect. We can see it and we can hear you, so we are good to go.
Okay, well, thank you so much for having me. I want to talk to you guys about the concussion management. Hopefully it's not something you already know, something new. I'm going to be talking about the multidisciplinary approach, including mainly what physical therapists can offer for the management. So first, so we all know what the athletic trainer's roles in concussion management. So you guys will do field assessment and daily assessment from there on. So you probably use standardized assessment of concussion or SCAT-5 or CAT-SIV, best balanced error scoring system or impact. Probably you do preseason or before the concussion, and again you compare the results as the concussion happens. So then you will do 6-step return to progression, 1 back to regular activity scores, 2 light aerobic activity, 3 moderate activity, 4 heavy non-contact activity, 5 practice, and 4 contact, 6 competition. And the ATC's roles are important. So ATC communicate with physicians, coaches, and parents, and then educate athletes. So again, you probably all know everything about this part. So I want to talk to you about post-concussion syndrome and how we manage it. So most athletes recover in 1 to 2 weeks, although research started to show it's really more like 3 to 4 weeks. And then if it's more pediatric younger athletes, it might take a little bit longer. So in general, post-concussion is defined, if you have concussion symptom after 3 weeks, that's becomes chronic and post-concussion syndrome. So then what are you gonna do is what I want to talk about. So if you already have all the protocols in place, so I think what I see is mostly, again, just like what I talked about, and afterwards is what we're gonna do. So again, concussion management, a multidisciplinary approach, and athlete trainers, you guys are the big part of it. And of course, physicians, team physicians, maybe once concussion happens, the athletes may go to their primary care doctors, emergency room doctors, maybe they go to neurologists, and then us physical therapists are some part of it. If this is not enough, the psychologist, psychiatrist, neurovisual specialist, and I didn't even list the whole list that might happen. So there might be dietitians, speech therapists, depends on what happens. So again, I want to talk to you about what I do. So concussion clinical evaluation. So hopefully in ideal situation, you have the athletes who had a concussion, and again, you communicate with team physicians, parents, and athletes, and they're just not getting better. So then hopefully your team physicians or many medical profession refer athletes to physical therapists, and then we do concussion evaluation. So what we do is medical history. So we go through the mechanism of injury, initial current symptoms, initial treatment. So what happened, like what they removed right away, or how they were responding during the first initial phase, and then histories, and we'll talk about or ask about prior trauma or history of concussion, cervical pathology. So did they already have any type of issue in the neck, learning disability, if they have ADD, ADHD, that might actually affect their recovery time. Um, and psychiatric history, maybe even have family history, and then anxiety, panic attack, that sort of thing. Migraine, headache history. Again, the headache is one of the symptoms. So if they already had some history of it, we want to know. And visual impairment history as well. We're gonna ask about the medications. Again, it's more like a physician's um, job to go over all the medications and take a look at it. And we ask about sleeping patterns, diet, hydration, caffeine intake, and we can go deep into what what they eat that might provoke the symptoms, stress, anxiety, and symptom assessment. So I usually give out post-concussion symptom scale so they can kind of check what the symptoms they have. And then depends on that, if they're mainly complaining about neck pain, and then we give out additional neck disability index. It's like a questionnaire. Or if they're more like headache symptom, main symptom is a headache, so the questionnaire may be a headache disability index. Or if their main symptom is dizziness and dizziness handicap inventory, they're all questionnaire that they can fill out. The clinical evaluation we conduct, the muscle skeletal assessment. So I'm a orthopedic physical therapist, and I'm trained in manual therapy. I'm a certified manual um, therapist, meaning that I'm trained to do a lot of hands-on stuff. I see a lot of spines, back pain, neck pain. So how we work in the clinic is, again, I usually evaluate the patient first, and I can do all this evaluation, and then, but I'm not a neurophysical therapist. I don't see vestibular issue daily, like the neurotherapist. So we work together also, and neurophysical therapists work together. So my part is, again, I evaluate the cervical spine, range of motion, segmental mobilities, soft tissue, motor control, positional sense, posture. A lot of times they might have headache or neck pain or dizziness from cervical issue. So I will evaluate and treat, because if they have a lot of neck pain, since they have to do a lot of neck movement for vestibular rehab, the neck pain needs to be controlled, somewhat controlled, and headache needs to be somewhat controlled before they see neurophysical therapist. So that'll be a big part of my job. So then I will still do, at the evaluation initial visit, I would do vestibular and ocular screening and assessment. So mine is gonna be more like a screening. Again, I might see spine issue daily, but neurophysical therapists may see the vestibular issue daily. So we kind of teamwork, and then treat, and then what we're good at. So the neuro, I can still do BPPV, rule out or assess benign proximal positional vertigo. So they can have BPPV after concussion, and usually it might take a little bit longer to recover compared to regular BPPV. And they're going to have balance dysfunction. So again, we might do BESS or CAT-SIV. You see the picture there. We have a kind of, it's called Neurocom. It's a big box, and we harness the patient. And if you can see, there's a screen and there's a platform underneath. And then you do balance test on the flat surface, eyes closed, and the bottom moves, and you put the cushion or RX, and then they have to stand balanced on the uneven surface, and then the whole environment, or just the wall around them, will move. So they kind of have to use all sensory to be able to balance, and it's kind of very difficult, but we have that to test clinical test of sensory integration on balance. So, and then we have a vestibular oculomotor screen. So I test smooth pursuit, saccade convergence, vestibular ocular reflex impairment, visual motion sensitivity, VMS. So basically, can they follow, let's say I hold a pen and they have to keep looking and go side to side, up and down. Convergence is, they have to put the pen and then get closer and make sure they're able to convergent the eyes to the target. And the VOR and the motion sensitivity is different ways to test the vestibular system. And they would say either you can see the eyes not following or not able to stabilize the gaze, or they might say increase the symptom, dizziness, headache, and whatnot. So separate from the other symptoms, we have to kind of dig into the headache. Is it migraine or cervicogenic headache, medication overuse, or neurometabolic fatigue, ocular headache, psychiatric headache? So if they already have a history of migraine, again, that needs to be controlled with the medication. So hopefully the physician can go over the medication, adjust, whatnot. and manage. Cervicogenic headache, again, that might be done by orthopedic physical therapists who treat the spine and cervical region. The upper cervical, like a C1, C2, that's where the things happening. So you need to treat that well to see if that help their, again, headache. Medication overuse headache. So sometimes they might be taking too much medication, and again, they're already kind of easy to be triggered by anything, and then concussion makes it worse. Neurometabolic fatigue is, they might say in the morning they feel okay, and then they go to school or read or walk in through the busy mall, something like that. At the end of the day or evening, they just get fatigued and the headache increase. So they're cognitively like fatigue. So ocular headache is just like I talked about the vestibular testing. So after they move their, eye movement cause the headache, and they might say, I have pressure, or I have headache behind my eye, something like that. And then there's a psychiatric headache. They might have a life event, stressful event, family, issue and then that might actually cause a headache. And of course, we can do only so much about it. So you might have to refer out to psychiatric. Um, and then the next one is exertion assessment. This is pretty important part, and I'm pretty sure some of the trainers are a part of, participate in this aspect. So what we do is the Buffalo treadmill test. So basically, we have them athletes walk and then get the heart rate going up and see if that will increase the symptoms. So Buffalo test, I mean, you can, if you're not familiar with it, you can Google, and there are different slightly different version of it, but basically you increase the heart rate and then how that goes. So for example, you use the Borg RPE scale, so rating of perceived exertion, and then so you put the athletes on treadmill and then start out, it's 3.2 miles per hour if they're 5'5" or shorter, and if they're taller, 3.6 mile per hour. And then you're increasing the incline every minute. So you get the baseline for the heart rate and then the symptom level, whether it's a headache or dizziness, and then start, and every minute you ask about their headache, their symptoms level, and then how hard the activities is, and then check their heart rate. So when they say my symptoms are going up, and we'll say by 3-point scale. So if their level is 1, and then they say it's already 4, and that's when you stop. And if they can reach to all incline up to 15 degree, then you're gonna start increase the speed, and again increase the heart rate and see what happens. And wherever the threshold, you're gonna, that's the level that you want to write it down. And so then the treatment from there is you're going to do 80% of their threshold heart rate, and then you're going to try to do 20 minutes a day, and then you're going to retest. I hope that makes sense. And then the next one is neurocognitive screening. So I'm sure most of you do impact preseason or before concussion, and you can compare. You can do SAC, different things to see what's going on. And then and I'll talk about that a little bit later on. So but that's the screening. And then mood anxiety screening, so you can pick a different questionnaires if that's what they're presenting. Okay, the next one is, so once you evaluate concussion, you want to kind of categorize them so you know what you're going to treat. So the APTA, American Physical Therapy Association, kind of categorized in 6 groups. So that's cervical, vestibular, oculovisual, cognitive, migraine, mood, anxiety. So what type of concussion symptoms that they have? However, for the most part, they're all mixed. So they don't have just one category. So they have probably maybe all of them, or maybe 1 or 2. So, but at least you categorize it and kind of treat based on what category they are in. So another Journal of Orthopedics and Sports Physical Therapy kind of did the different way. So they categorize into 4 category, and then they have cervical musculoskeletal impairment, vestibular ocular motor impairments, autonomic dysfunction and exertional intolerance, and motor function impairments. So it's slightly different. I think both are good in different way. I'm going back to the slide. The APTA one, actually, they don't have exertional intolerance. So I think it's important. So I like the JOSPT domains. However, the other one doesn't have cognitive, migraine, mood, and anxiety. So JOSPT one, actually, I think they value these 4 categories because this is what physical therapy can kind of address. So cognitive, migraine, mood, anxiety were kind of still addressed, but that we're not, if this is the main one, you might have to refer them out to different healthcare professions. So whether to physicians or possibly speech therapists or psychiatrists, but again, we still address to some extent. So but just the point is to kind of try to categorize and then target. All right, so the treatment is address impairment. So after you evaluate them and categorize them and you realize there are multiple impairments that you need to address. So you're gonna address each of them. So instead of talking about any possibility, because there are so many that you can do, I'm just gonna provide a case study just so you get an idea. Case study 1, it's a male college diver. History is he hit the head on diving board and referred to PT 2 weeks later. Symptoms is neck pain, headache, dizziness. Clinical findings is upper cervical malalignment, post-concussion BPPV. And then the treatment was, again, to address what you find during the eval. So what we did a manual therapy by orthopedic physical therapists for upper cervical malalignment, and then BPPV neurophysical therapist did the Epley's maneuver. So the important thing here is we've seen not just football players, not just lacrosse players. So I think concussion can happen really anybody. So it could be diver. We had track and athletes who were on crutches for the stress fracture and she fell on stairs. Again, it's not, I think trainers may not cover all this high risk sports, but that can happen to you. So, and also the important thing here is, I said prior, the post-concussion is when they have symptoms after 3 weeks. but we can start addressing the impairments pretty early on. So ideally, I think, if you have athletes and you do the daily assessment and symptoms are recovering, then that's fine. But if they're like, okay, their day 7 is the same as day 5, ideally, I would like to get phone call from ATCs or team physicians and, hey, we have this athletes and you might start to see him or her. And then it might be, I get the phone call Friday afternoon, evening, and then like, okay, we need to see her Monday. So, we have to verify the insurance and all that stuff. So that might not happen, the same day or the day next day. So again, I think this is the kind of important part. You don't have to wait for 3 weeks to refer them out. You might want to talk to physicians and kind of, again, if they're really not moving forward like you would expect, you might want to think about physical therapy. So the case study 2, it was a lot more complicated. Female college volleyball player, ball hit her head, which probably happens all the time. So she didn't think of anything. She had mild symptoms, but just she was like, maybe I was tired, maybe we were traveling for the games, maybe I was stressed out, and didn't even tell athletic trainers because she wasn't even aware that was concussion. So months later, she told her athletic trainers, hey, I really have kind of headache, dizziness. And then, so she was really chronic at that time. So her symptoms were headache, dizziness, and then the findings were convergent insufficiency. So if I put the pen in front of her and get close to her nose, her one eye doesn't convert. So her one eye just kind of stayed out. Ocular headache with VOMS. So if we do vestibular testing, she gets headache, kind of back of the eye, that kind of headache. And the increased symptom with exertion. So again, we put her on the treadmill and increased the heart rate. And at some point, she had increased symptoms. And then decreased attention and concentration. She would have hard time going to the game, the basketball game. There's lights and big sounds and stuff like that. Concerts. She wasn't able to get places like that because that would just bother her. So the treatment is, again, the big one was convergency insufficiency. So as you see the picture, pencil push-ups or boxing exercises. So she would stabilize the gaze and then try to look closer. So the beads and string, you put that from nose and try to look from the far to close to the middle. That's the exercises that she was doing. The treatment, so because of the ocular headache with VOMS, we kind of expose the athletes to basically get used to it so the body will know how to handle it. We do have this, in this picture, we do have this equipment. It's a part of the other box that you saw earlier. It's the other part that we can do. So there's a eye sensor. I wouldn't say eye, like a head movement sensor. So you put the this sensor on top of the head, and then have them move their head and keep the eye on the screen to read the letter. So if you, I don't know if you can see closely. So the head movement could be horizontal, vertical, and roll. Roll is like a lateral flexion, side to side. And then the little E shows up, and then E, like a opening up, is it up or down, right or left? So as they move their head, they have to read the letter, and then they have to move faster, or the E gets smaller and smaller, or it's like a flash, so it shows up like shorter and shorter, and then we find what level they're at, or what symptoms they're gonna get, or which direction they have difficulty with. So it could be when they have more difficulty with horizontal or vertical, uh, then that's what we're gonna do as a treatment. And again, this is the kind of fancy equipment, but um, we also do the dots on the sticky notes all over the clinic, and then they can do different treatment just with the simple sticky notes and pen. All right, continue. So she also has increased symptoms with the Buffalo treadmill test, exertional test. So her heart rate threshold where she gets increased symptoms was 140 beats per minute. So target exercises level is 80% of that times 20 minutes daily. So nowadays a lot of athletes have doesn't have to be fancy, but the smartwatch. So we use the smartwatch so she can do exercises on her own. So she knows, what heart rate she has to get, and then do 20 minutes of whatever, walking or, treadmill or whatnot. You see the picture, the bottom picture is the anti-gravity treadmill. I like to use that because I feel a little safe. They won't fall out of it, not like a regular treadmill. So, and then I still do a little bit of less weight, so they have a little bit of support. So obviously before symptom goes up so much, will stop, but occasionally, people kind of get increased symptoms, and we gotta be safe. So that's why you see the Auto G treadmill there, but obviously you don't have to have it. So then you can retest and progress and see if their threshold is better, and then kind of adjust the treatment. So cardiovascular conditioning, and then eventually you can add movement-based rehab. So initially they might be looking straight and walk and get the heart rate increase, but eventually if they can tolerate, you can start having them look around side to side, again based on what you found with the evaluation. If they have issue with the horizontal or vertical, then you're gonna have them look up and down while they're walking and getting the heart rate up or something like that. And again, you can combine with the vestibular habituation rehab, and eventually your treatment is gonna be more sport specific. So and then you see the screen there. This is the tracer. It's like we fit on steroids. So you see the kind of blocks under the screen. So you have to kind of hit the target and with the speed that it's required. So you cannot go too fast or too slow, or then we're gonna have them go back and forth, side to side. So you're the bumper shows up, and you have to move to the bumper and then control motion. And again, this can be done like, there are so many programs in this, so you can do like squat, jump, lunges, move side to side, zigzag, whatnot. So again, depends on what they're gonna need. Like I talked about, co-treat with the neurophysical therapist. Once they are improving vestibular system, and they're able to do a lot of exercises, uh, they'll come back to me. So first, I'm gonna do evaluation, kind of treat the cervical part and do whatever I can, and then they usually move to neurophysical therapists, they can, you know, treat the severe system. Once they're moving forward, they might come back to me so I can do more sport specific stuff. So for the volleyball player, she had a hard time again under the light. So I will have her look up to the light, squat, jump and turn, and hit the ball, stuff like that. You can go pretty creative and fun. So there's no much research on how much you can expose them to. So some for example, the patient that I had, and he went through similar rehab, and he just wasn't able to progress because he would just stop as soon as he feels symptoms. He would stop. So but this is the habituation, so you have to expose them, and I'm talking about this is chronic, so it's not an initial few days, anything like that. So you're gonna expose them to the whatever the stimulus, and then have body, you know, learn how to recover from it, or not deal not have the symptoms. So again, we don't exactly know how much we're supposed to expose them. So is it, do we have to stop when they have a moderate symptom, 4 out of 10, or do we push to the 8 out of 10 to the point where like throwing up? It depends on the therapist, I think. Some neurophysical therapist who's trained for post-concussion management, I mean, you know, some therapists might want to push really hard, or some may not. So we just don't know quite well how much. However, what I think is, I mean, I would say kind of progress as tolerated, and you expose them to, let's say, 3 out of 10, but they can recover in a minute or two, and then they can walk out of the clinic with going back to the baseline. They come back and they said it was okay, then I might start doing, you know, push hard, and I feel that works. Okay, now again, continue. So treatment continues. So she did have a decreased attention and concentration. She would say, you know, if I look into the slides and trying to study, it does bother her and feels like head is, you know, little pressure and stuff like that. So we do have, it's called BITS, Bioness Integrated Therapy System. So it's a different screen again. As you can see, the screen kind of shows maybe the letters, words, numbers, and then you have to touch in order or backwards. So what it shows here is you have to touch, well, I don't think it's even right. So the number, you go back from 4 and then go to the A and then 3 and then the B, and then they have to kind of follow the pattern and touch and then disappear the letter or number, stuff like that. On the right side, so there, I mean, again, there are so many programs that you can use on this, but on the right side, the circle, in the circle, maybe the letters or whatever the patterns of words might be circulating, and then you have to find the words. Maybe you know, depends on the program. They might say word, and you have to kind of quickly disattach to make it go away. Anything, I mean, you can think of, they have it. So go back to we did the cognitive part. I said the Journal of Orthopedic Sports Physical Therapy domain don't include the cognitive part, but I think we can still address that in different ways. Okay, so the outcome, I want to say she got better and we can discharge her. No, she didn't. She continued to have the issue. I mean, she was progressing really nicely. Again, she could go to the concert. She can, you know, be pretty much symptom-free. However, she just continued to have convergency insufficiency, and whenever we do that exercises or she has to do something similar to that function, she still got mild dizziness. So we ended up referring her out to a neurovisual specialist, and she got the prism lenses, and that's how they correct the convergency insufficiency. So again, this is all about the multidisciplinary approach, and everybody has a different task and kind of treat what was found. Okay, so consideration and recommendation. I'm assuming if you're athlete trainers and working in the organization, you already have protocol in place, like college, high school, you know, wherever you are, you probably have protocol in place. You already have relationship with the primary care physicians. And then hopefully you know, if you don't, or if you talk to the physicians and he or she may not know what's the next thing if they become chronic, then you might want to start looking into who is available. So physical therapist, again, neurologist, like I say, visual specialist, psychiatric. So it's, again, the chronic concussion, post-concussion syndrome may not happen that often. I guess research shows 1 out of 4 may become more chronic, but there are so many under recognized concussions. So, and if you have few and then one become chronic, and again they have to know what to do with that. So know when and who to refer. So again, I'm not sure how often that's happening, but again, if you're like, all right, this is day 7, day 10, and they're really stuck in one phase, you might want to start to think about that. And again, communicate with the physicians, and if other health professions are included. Again, ATC, you guys are the one that's communicating with everybody. Continue to communicate, educate with the athletes and parents. So again, if you can take, if you can take this out of this webinar, is understand the multidisciplinary team approach. And again, if you can have that system in place, that's great. If not, you can start thinking about it. So that'll be a important thing for your, already busy day. So I think that's it. Any questions?
All right. So we've already had a couple of questions come in. The first question comes from Sarah, and she asks if you have a typical decision tree that you go through for post-concussive recovery and treatment plan. And then she also asks if you have a resource, maybe that could be shared with the attendees.
Can you repeat that again? So resource for what?
The way I'm reading this, it's asking for a decision tree resource, which sounds like almost, okay, someone has a concussion, they're going on and having persistent concussive symptoms. These are the potential areas where those symptoms can fall into: neurovestibular, the visual or ocular, and then a decision tree from there.
I think team physician is gonna have to make a decision, but again, if the team physician who's trained to manage the concussion should be the one that make a decision, but we as a physical therapist can provide detailed information as to, all right, this athlete has this and that. Is that, I'm not sure if I answered the question.
Yeah, I'll give her the opportunity if she wants to jump back in with a follow-up question. And then another question is about, so there's a few different definitions, and then there has recently become some, not controversy, but the discussion of post-concussive syndrome potentially being renamed as persistent concussion symptoms. And then at what point, some of the literature talks about 4 weeks, some 6 weeks, and some 3 months when they transition into more persistent symptoms. Where do you fall in those perspectives, and does that duration of time change your management?
So is concussion treatable and decrease the amount of time to recover? Yes. By doing what I just talked about. And again, I'm not sure if I understood the question. So where does this follow? I mean, any time, again, when they become not able to recover, like when they are not able to progress through the stage. So it could be, again, 10 days, months. I'm not sure if I understood the question. This could be done to any athletes day 10 or months later.
Right. Right. Yeah. The definite. Do you have any opinions on? There is some perspectives that it's no longer going to be called post-concussive syndrome, and instead going to be called persistent concussive.
Oh, okay. I think I understand. I don't know if there is a clear line or if there need to be, in my opinion, because again, we evaluate and have the impairment findings to treat. So when they, so I think, it's like low back pain becomes just pain. Not becomes orthopedic true pain. It's kind of similar. Concussion becomes like, just the symptoms. But we still treat the impairments. That's why I think it's important to be able to evaluate what the issue, because if you don't know, it seems like, they just have a symptoms and forever and never, and so I think we as a physical therapist may be able to pinpoint, to be able to say that or not. So is it the clear definition? Is it clear definition is, again, evaluate and what they have. If they have impairments, and that's what it is. If they, I would say, I shouldn't say occasionally, but sometimes it becomes only truly more the psychiatric issue. So I don't know if they have not that they become not so much concussion, they become more psychiatric, like let's say the diagnosis would become more anxiety than post concussion, but it's still blend, but the ratio becomes more towards that, just because it's triggered by concussion or hit in the head. But that, so there's no clear definition, and I think I know what you're talking about, because that's when we are like, so what do we do, but again, if there is an impairment, we treat them, and then when becomes something that we cannot treat, then again, you might refer them out to different profession when it may not be so post-concussion syndrome.
Okay, the next question comes from Gabrielle, and she asks, how would you go about distinguishing an athlete who has concussion symptoms, and I'm presuming that this is more acutely, an athlete who has concussion symptoms versus dehydration or heat related symptoms? For example, there was a hit involved, but the athlete is also stating that they're dehydrated.
So again, I mean, this is a the concussion is like so wide range of things. So I actually dehydration or diet are part of the again history that we, the question that we ask, and actually that's part of the treatment as well. So the concussion, I think what I'm trying to say is, if they're already their nervous system or body system is heightened then they're easily be concussed and becomes symptomatic as a post-concussion symptom. So again, how do you know? And again, I don't do on field assessment to say, but if let's say if they're becoming more chronic, so let's say they got concussion and they're not recovering, they're dehydrated. It is actually concussion because they have a concussion symptom, but could be triggered, or they can recover because they're dehydrated. That happens. So again, the diet, hydration, that's actually part of it. How do you know? Can you rule out everything else? So do they have actual vestibular issue? Do they have, let's say, if they're dizzy or headache, and if I treat upper cervical, I kind of should be able to provoke or increase the symptoms that they have. So it may not be that clear, but again, you evaluate and rule out.
Yeah, perfect. And then even Gabrielle, if you can't rule it out, certainly treat them as if they're a concussion. If you have them sitting on the sideline and you get them rehydrated and their symptoms don't resolve, they're still having persistent symptoms, I would treat it as a concussion. No one's going to fault you for being overcautious about a concussion versus chalking it up to dehydration and then having something more significant happen.
Yeah, I can see how difficult that becomes, because again, sometimes we rule out everything, and then you for the most part, the patient that we get is we're gonna find something. So I again, you probably have to refer them out to be evaluated very thoroughly, and if everything is ruled out, what's out there, you have to dig in deeper. So if the dehydration is the only thing, and you hydrate them and not going away, there might be something else that you don't know yet. And again, it could be, because again, we had athletes and the symptoms are not going away, and then again, we ask all sort of questions and life events, and and then like sleep pattern and everything. So you kind of have to address, so if the hydration is part of it, diet, like sleeping pattern, also, like again, this is actually the important part of the ATCs, because you guys see athletes and you know them daily, and you kind of their schedule. So it could be just anything lined up with that. So we had athletes, and then the symptoms are not going away, and then he was going through the finals and studying and sleeping 3 hours. Well, of course you're not getting better. So is it concussion? Well, concussion that I can treat, no. I mean, I would encourage you to use your smartwatch or cell phone and, put your alarm and sleep and, hydrate yourself. But there's no clear concussion it's never be clear cut. It's always the gray. But you have to kind of, again, try to categorize and treat. And I know I'm not answering, giving you a clear cut perfect answer, but I know it's always the difficult part. So you kind of have to keep digging in.
Well, wonderful. I think that's all the questions that we have. And so thank you so much for a great presentation. It's perfect timing for it. Getting ready to start the preseason spring games, preseason football games for the fall season start for us on Friday. So not sure about everybody else, but definitely a timely presentation and really good information here. So thank you very much for a great presentation, and thank you to everybody for attending.
Thank you so much for having me, and thank you for all the questions. I hope that was helpful information.
Yes, and Gabrielle posted, it makes sense, thank you. All
Thank you.
right, have a good night, everyone.
Have a good night.